So in general, as we've talked about, you always have to kind of individualize your treatment plan for your patients. And so when I look at my patients, regardless, we're looking at whether it's sports injury, fracture, arthritis, there are a lot of factors that you have to take into account of the patient that can affect how you're going to treat them. And so Sheldon Lin has this pseudonym called HONDAS, which I think about all the time. So obviously high BMI, older patients, osteoporotic, neuropathic, diabetic, alcoholic smokers. And all this goes into your mind about how you might treat the patients because you want to try and minimize some of those confounding factors. So certainly from a hardware standpoint, you want to maximize your bony surface area. You want to make sure, as we've talked about, get a good reduction, and then make sure you protect them enough so you provide a nice stable correction that's long lasting. And I always think about what's my recipe for bony healing. We've heard about this a lot last night and today. So you want to think about the patient's blood supply, what's their nutrition, how it can provide the best bony stability. Is there anything else we can give them, bony stimulus, biologic stimulus, and obviously protect them. So Wright Medical has this new ankle fracture plating system now. It's been multiple plates and multiple different types of screws. It's type 2 anodized, which makes it nice and smooth. It's almost like you can think about the Zamboni smoothing out the ice rink. So it's nice, smooth, it's very thin, but it's actually very strong, even stronger than steel. So some of these plates are good, like we were talking earlier about the posterior malleolar fractures. So where you want something that's very low profile, these plates are really good for that. Have a lot of good uses. They also have a syndesmosis fixation device, which is similar to an older generation of the tightrope in the sense that you do have a medial incision to try and minimize any neurovascular impingement. But it does have one knot that is low profile that sinks into the plate so it's not proud. So obviously you can help treat your fractures like this. They also have the small bone plating system, the Orthodox 2, which has a lot of applications specifically for metatarsal fractures. So these pinch plates I think are really helpful for metatarsal fractures. You can use them for neck fractures, you can use them for shaft fractures. This is a patient that had multiple fractures here, but you could also have a patient, if you saw a patient that had a non-union of a minimally invasive approach to a metatarsal neck fracture, while these are good as a salvage option for that as well. This is a shaft fracture if you'd like to treat these. The plate works well for this. They also have T-plates that work really well for this, so you get good fixation when these fractures are a little bit more distal. You can get 2 points of fixation distally in the head with the T. This was a patient I actually operated on yesterday. She has this metatarsus adductus. She doesn't really care about the bunion, but her second and third rays really hurt her, and so these plates are really handy. So I did this rotational osteotomy proximally, and then a really good fixation across the osteotomy site. They're also very helpful and give us a lot of good options with fifth metatarsals, and so we're going to have a talk about this tomorrow as well, but just to dive into a little bit. So for the zone 1 injuries that go on to a non-union, I think these are really helpful because the hook is there where you don't necessarily have a lot of real estate to get screws in, so you have a good fixation there, can provide nice compression. Classically, the Jones fracture, we're doing these now percutaneously with the solid screw. And the question is, should we really be operating on these? I know that we used to treat most of these non-operatively. Now there's been a trend more toward operating on them. And so I think when you're thinking about whether you want to operate on these patients, you really want to look at the literature. And so the concern, if you don't operate, it's obviously a longer recovery, potentially longer time to weight bearing, longer time to return to work or to play. There's also a higher delayed union rate, higher non-union rate, also a higher refracture risk. So I think you have to take all this into account. They have a new fracture system now, and all this stuff, by the way, is outside of the booth that you can pass by and take a look at. So it's a titanium system now. They have headed and headless screws. They have chamfered heads, which I'll talk to you about. And screw selection is really important, I think, when you treat this. So you ideally, you want to try and focus on a solid screw. Cannulated screws can bend or break, especially if they're small. There have been multiple studies that have shown that you want to try and get as big a screw as you can get and make sure that it's not too long. There have been some studies that have shown that some headless tapered screws are not as strong and about 67% of strength to pull out. So my preference, especially in athletes, is to do this percutaneously. I use a solid screw. I really open it only in a revision setting. I want to choose the largest solid screw that I can comfortably fit in the canal. So I'll start with the 4 or 5 drill and 4 or 5 tap, and I'll go up from there, 5, 5, 6, 5 if I need to. You want to make sure that you pass the fracture site with the threads, and you want to make sure you avoid straightening the fifth metatarsal. So the metatarsal is not always straight, has a bend to it, and so sometimes you can cause a malunion, malangulation at the fracture site if you're not careful. So we were all always taught to do it high and inside, and I still kind of aim it through there. I mean, percutaneously, you're trying to get center, and you want to aim for the center diaphysis. You, again, want to not violate that curve, because if you do, as you can see here, you can violate it in this patient immediately with that banana-type shape of the fifth metatarsal and cause a fracture. Wright Medical now has this guide, so for those of you that are more occasional users of the system, this guide theoretically could help to help you locate the center, which is located here. And again, this is outside. You can take a look at it. We can play with it in the lab. Sometimes patients complain of a painful screw head with these solid screws, for the headed screws that can impinge on the cuboid. So now what are you going to do? So obviously you can remove the screw, and typically that takes care of the pain. But now they have this chamfered head on the screws that you can use, so you can rotate the screws such that the chamfered head is on the side facing the cuboid, so you can remove the impingement. They also have another option. You could go to this dual headless compression screw, which you can place in, you can see here, which is a cannulated screw. I don't use that screw in particular, but it can definitely sink. You can countersink it so that the head's deep inside the bone, so you're not going to impinge on the cuboid. But in general, I don't think this should be your primary option in most fractures, because as I'd shown previously, these screws are not as strong, especially to pull out strength. It's also going to be a lot more difficult to remove if you have to take it out, as opposed to the headed screw, which is pretty prominent and you can get it out pretty easily. Now, what about cases when a screw is not the best option? So sometimes the patient has a certain bend to their fifth metatarsal, so it's going to be really difficult for you to get the screw adequately across the fracture site and not fracturing the cortex. And so sometimes plates are a good option. And so there's certainly some benefits, especially in non-use situations where you're opening it up. Then you'll have direct access. The plate, especially on the tension side, has been shown to potentially be superior to having an intramedullary screw. You can avoid disrupting the intramedullary bone supply when you do that. But the cons are that it can be symptomatic, so about 10% of hardware is going to be symptomatic. You're going to be stripping at the fracture site. It can create a stress riser at the end of the plate, so then the question is what size is going to be the right size of plate to use. So routine plate fixation, I don't think is necessarily indicated. It's a longer recovery of wound healing issues. And then what happens if those screws fail in the canal? What does that imply for your revision? Sometimes it can be really tough to get those out, and then that can complicate how you're going to revise that. So this is a patient, this is a case of Dr. Anderson's, a Division I point guard. He had a refracture, and you can see the screw size probably a little bit smaller, a 4 or 5 screw there, but there was a little bit of a bend, so it might have been tough for him to get a larger size screw across the fracture site. But this is a refracture. And so this was a good indication for a tension site or plantar plating, and then healed the second time around. And there has been some literature out here. This is from Varner's group in Houston, showing success with these 8 male athletes. But the one thing you should see is that 2 of these patients, so 2 out of 8, had a sural nerve neuropraxia, but 100% healing at only 6.5 weeks. So it seemed a promising technique. The advantages are that it's similar to anterior tibial plating. It's much stronger. You can convert the tension forces to compression. You get very good purchase, much better torsional resistance. So especially even in a revision setting, and this can be a very good option. And then you can bone graft across the fracture site. What if this fracture doesn't heal? So sometimes you could have an incomplete union. You could have a painless non-union. So I would say in that situation, if it's asymptomatic and you have relatively good hardware, so there's nothing broken, there's nothing prominent, you can probably just observe them for the most part. And as long as it's asymptomatic, you just kind of follow them. You can give them some Shearer modification, potentially do some extra stuff such as a bone stimulator, maybe alter their diet, do some vitamin D supplementation, shockwave therapy. This study came out which showed 48% of patients with stress fractures will have a deficient vitamin D, which we heard about last night, so you can certainly supplement them. But along the fifth metatarsal, these zone 2 and 3 injuries, true refractures do happen. You can see here throughout the literature anywhere from 9 to 30%. And it doesn't really seem, when you look at the literature, it doesn't seem to matter how quick or aggressive their rehab is. So they tend to usually occur within the first year. But the question is then, with these patients, is it more of a biologic problem? So is it really could be a vitamin D issue, let's say, as opposed to a stability problem. So there was a study that looked at some NBA players, these 10 athletes, that some players are different. So we tend to associate these fractures with people who have more of a Chiari malalignment. But it was shown in these athletes that went on to a non-union, so a pretty high non-union rate, 30%, that these patients had actually more of a planus foot and had metatarsus adductus, and did have a slight curve to that fifth metatarsal. And so they usually had a callus plantarly on the base of the fifth. And so these patients were a little more different. So when you see patients like this, especially athletes, because we want to get these athletes back as quickly as possible because it's their livelihood, these are patients you might want to think about getting an early MRI on, because sometimes patients like this that have a stress injury, maybe even a stress fracture, these are ones that are more likely to go on to developing a complete fracture. At the same time, when you fix these patients, these are patients that I would have a lower threshold to actually open bone graft them instead of just doing intramedullary bone grafting. And I might do extra stuff as well, augmentation with bone stimulation and shockwave. And these are ones that actually delay going back to sport. So a lot of times I'm aggressive in letting them return to sport as early as 6 weeks so they can tolerate it. But these are ones that I definitely would wait until 3 months to let them go back. Now, what about if they have a refracture non-union if they're symptomatic? So I think certainly you're going to consider removing the hardware. Sometimes you have to do corticotomy to actually get the screws out if it's broken. These are patients that, again, you're going to want to do an open bone grafting instead of a substitute. And then you're going to talk about refixation. So if it's a screw that's in there, they have a relatively normal alignment to their fifth metatarsal, then usually you can upsize to a bigger screw, and especially if it's a cannulate screw, you want to make sure it's a solid screw. Plating is also a good option right now on the tension side, and again, augment with bone stimulation and diet supplementation. Fortunately, revision procedures are very successful. There's a study by Dr. Anderson that showed that all of his patients basically healed, only one refracture. And that's why we can really be aggressive with a return to play. So as Dr. Anderson had said, with his pro athletes as well, he gets them back very early, especially if it's, let's say, an early or mid-season injury, because he wants to get them back on the field during that season, because it's, again, their livelihood. Worst case scenario, if it doesn't heal, if it refractures, then it can always be fixed in the off season. So again, now turning our attention more to biologics and some of the products that Wright Medical has. So when I'm thinking about my recipe for bone healing, certainly whatever stimulus we can do to get the patients to heal, taking all the confounding factors into account. So what are some biologic stimuli that we can use as well? So ideally, we want that patient to have an optimal biologic environment to heal. So that includes some kind of scaffolding, which provides some structure, some kind of and signaling, recruitment to get the appropriate cells there and create the appropriate environment, and then something in there to get some live bone-forming cells to generate new bone. So certainly the gold standard has always been autografts. It provides osteoinductive, osteoconductive, osteogenic features. There are risks and costs associated with that. Certainly there's a limited supply. It's a little bit more OR time, a little more anesthesia. You have the supplies that you have to use for the harvest. There are multiple studies showing the morbidity of bone grafting as well. And just the harvest alone can create significant complications. So this particular study found a 50% donor side pain at 24 months, which seems like a little high, at least anecdotally from my practice, but it's out there in the literature. There's a meta-analysis. So there are some bone graft substitutes that we can use that are specifically shown in the foot and ankle to be as good as autograft in primary fusion type settings, and so they can be very convenient to help us augment our biologic environment. So Wright Medical has these two products, ProStim, which is calcium sulfate, calcium phosphate with DBM. This is more of a mix between something that's structural and something that's osteoinductive. So this is something that you want to put in an area that has an open bone void or a gap that has relatively good blood supply, and it can generate new bone. And so this is something that works very well, for example, in a core decompression type of setting. If you're looking more on the osteoinductive side and less structural, that's more of this demineralized bone matrix product, which has a lot of growth factors built into, and this is something where you want to stimulate bony healing. So callus formation, fusions, stuff like that. If you need something more structural, which is a good indication with cysts or anything with articular surface depression, then you want something a little bit stronger. So that would be the ProDense product, which is a calcium sulfate, calcium phosphate mix, which is much more of a scaffold or structural support. An interesting thing is that it sets strong, so right away when you put it in, even when it's wet, has a a very strong initial compressive strength, almost 4 times the strength of cancellous bone. So when you're thinking about cancellous chips versus this. It also resorbs in a triphasic type fashion so that new blood vessels can come in and help promote new bone formation. So when you compare it to just a straight calcium sulfate, you can see here that over time, the mass and the volume gets smaller. But when you look at the mixed calcium sulfate, calcium phosphate, you can see that the mass gets smaller, but the volume is maintained. And you can see over time that even at 13 weeks on the left side, you can see how in the ProDense product, how the new bone has been regenerated. But in the calcium phosphate graft on the right, there's little to no graft resorption. So it's integrated, it's not regenerated. You can see the timeline here going from implantation to 26 weeks, how the bone gets completely regenerated, whereas the phosphate does not, it just stays there, does not integrate. And overall, the ProDense can also remodel to normal bone. So if you see the histology on the left there is what normal bone looks like. If you look on the right with the ProDense product, you can see the revascularization, remodeling the bone looks very similar. And the studies have found that you actually have stronger new bone. So after the ProDense has been resorbed, you have 6 times the compressive strength as you would versus autograft, much more compressive strength than actually the normal unoperated bone, even at 3 months. And you actually get a faster and denser bone repair, 3 times more bone on average in your repair. So there are many good applications for this. So certainly tibial plateau fractures if you need to place the metaphysis, calcaneus fractures in similar fashion if you decide to use product. Also large cysts throughout the bone, calcaneus, metatarsals. This is a very good product because again, you're providing structural support. This is a patient that I saw a couple weeks ago who came in. So this is a, I don't know if you can see it so well, but this is a type 2 navicular. So this was a non-union. That's 4 months out, and she also happened to have just medial to that a large cyst in the bone there that abutted the tail navicular joint. So this was a good case where I could go in and I could debride the fracture, the non-union site, and then I was able to fill the cyst with the ProDense, and then I fixated the fracture. So she's a few weeks out now. It's also been shown to be very helpful in total ankles. So total ankles, we're always worried about cystic changes and over time and osteolysis, and it's been shown to be very helpful with that. And I think we're seeing this more and more as we're revising a lot of the total ankles. And so in general, when I see and I have concerns with cysts after total ankle replacement, I'm looking at the implants. I want to make sure that the implant is stable. And if that implant is stable, then potentially we can bone graft these lesions with this ProDense product. So we can make a small incision. We can create a cortical window where the cyst is, which you've localized from your multiplanar imaging. And then once you're in there, you curette the cyst, debride the fibrous material, and this ProDense is a good option. So this is a patient that I'd seen. He had previous surgery, and then you can see he had retained hardware. And then we did the total ankle, and I took out the hardware, but where those transverse screws were, there was still some tracks where the screws were that abutted right where the tray was. So he was doing well, but then at 2 years, you can kind of see at that lateral border of the tibial tray stem interface, you can see there's a cyst there. At this point, he was asymptomatic, but a year later, he started becoming symptomatic, and you can see that it was progressing. And on CAT scan, you can see that there was a fracture. You can see a fairly, good-sized cystic lesion there, anterior laterally and posterior laterally with the break in the cortex. So I felt that there was otherwise some relatively good containment there. The implant was not unstable, and so I injected it with the ProDense, and that was 1 year out. So 1 year out, and he was asymptomatic. So now switching to another product, which is Graft Jacket. So Graft Jacket has been around a long time. So this is a human acellular dermal regenerative tissue matrix. And you can see it right there. It's that pad. It has a porous kind of coated surface, which almost looks like the surface of the moon, and that you put on the more vascular aspect of the tissue. This is very strong. It has multiple applications throughout the body. So it's been used in rotator cuff repairs, hand, large joints, and in foot and ankle, the Achilles, tendon augmentations, even heel pad augmentations. And it's fairly thick. They have thinner and thicker models. So some of the better applications in the literature, so you can augment primary repairs. As you can see down there with Achilles tendon repairs, it can give greater strength. It can also allow for earlier mobility or loading in certain soft tissue injuries. So you can see here, used as a spacer potentially when you're resecting a tarsal coalition. So this gives you something that will stay there. So that's a good application. You can also use it for hallux rigidus. which is how I first started using after Burlette published the article. So this is a good way for an interpositional arthroplasty, so you can essentially resurface the first metatarsal head, but also the metatarsal head sesamoid articulation when you tuck it underneath and you pull the sutures through the top. So I think this is a really good application of this as well. The difference with the GrafTech now is it's pre-hydrated. So in the past, you used to have it sit on the table for about 15 minutes and soak, and now you don't have to do that anymore. The way it works is essentially, it's a dermal matrix, but there's a lot of growth factors that are added into there and retained, and so that's how it stimulates a healing response. And then finally, amniotic and placental tissue. This is the picture of the placenta, and you can see the amniotic membrane is composed of the amnion and the chorion. And basically, the amniotic membrane, the fluid, has been shown to help promote tissue repair and wound healing, minimize scarring. It also has angiogenic growth factors that can help promote revascularization. So this is being used in a lot of different indications now. Wright has 2 products. One of them is a patch, which is called ActiShield. This comes in different thicknesses. So the one thickness, the chorion-free, is more like almost like a tissue paper. The chorion base is a little thicker. They also have an injectable matrix called ViaFlow. And basically, it's been reported in the literature for multiple uses. So there's a lot of literature in the knee for knee osteoarthritis that has improved pain, function versus HA and saline. So I do knee surgery as well, and so in arthroscopy I've been using it. The amniotic tissue doesn't have any stem cells, so it's cryopreserved, so there's no stem cells, but it does retain a lot of the growth factors from the placenta, including much of the same proteins and growth factors that's in PRP. It actually retains hyaluronic acid, so it can be very helpful with arthritis. It can be very helpful, the patch, with hallux rigidus. When you're doing a correction, if you're doing an open incision, you can lay the patch down to minimize scarring and maximize your range of motion. It can be helpful with tendon tears, tenosynovitis, as you can see here on the lower right. It's also been written about chronic heel pain, Achilles tendinopathy, plantar fasciitis, injectable as well as a patch, and then wound healing as well to try and minimize scarring. So this is a total ankle, and you can lay down as you close the deep layers in the capsule, and then in the superficial layers you can lay down whether it's the injectable or the patch, and that can really stimulate a healing response. So hopefully if all our patients would have wounds that look this great at 6 weeks. It's, again, very useful for plantar fasciitis, Achilles tendonitis. It has an anti-inflammatory effect, but as opposed to steroid, it can be a longer-term treatment. It can help reduce the scar tissue, enhance healing of micro tears. This was a study that was done that shows a retrospective clinical evaluation of his take on this, where he actually does an open approach and debrides a little bit of the plantar fascia and then injects this there. And basically, they're very successful, 25 procedures, and basically had complete resolution of pain for these patients that had chronic plantar fasciitis of 2 years. They were weight-bearing tolerant afterwards. So Wright Medical has a lot of different all right, so thank you. So Wright Medical has a lot of different these things on display at their booth for the hardware and the biologics. So I encourage you to go out there and take a look. And I was wondering if there are any questions.